All right, so we shall begin. I'm Roberta Garceau, and first and foremost, thank you for giving up your lunchtime and for inviting me into your space. I really appreciate it. Can everybody local hear me okay in the back and everything? Okay. If at any time, just give me the wave. So I am a dentist. I've been a dentist here in town for 30 years. I'm Connecticut born and bred. I went to University of Connecticut for dental school, and I stayed another 2 years for residency and fellowship in advanced education, general dentistry. I've always had a strong interest in occlusion and alignment. So I've done Pankey and Dawson and other places that you may or may not be familiar with. And always a holistic approach to wellness. You know, like we're getting more and more evidence since I graduated about the systemic connection. But really not just looking at teeth and gums, but looking at people and treating the whole person. So about 12 years ago or so, I got interested in sleep medicine, dental sleep medicine. And since then, I went through the process of becoming a diplomate with the American Board of Dental Sleep Medicine, which means that I've taken hundreds of hours of CE just in sleep. And I've submitted cases to be reviewed and pass the comprehensive exam. So it designates a different level of commitment and knowledge for sure. Because not all dentists are created the same. I always say we know what we know and we don't know what we don't know. So sometimes people who have sleep apnea will say, oh, I'm going to see if my dentist will make that for me. And maybe their dentist will. And I always say, well, ask them, like, how many do they do a month or a year? You know, right? Because they're not a bad person. They're probably well-intended, but we go with that. And so that is the distinction I have. And then about 10 years ago, I was called like a nun to become a yoga instructor. Like it was just like, I couldn't explain it. I'm like, this does not make sense. And so now I have over 800 hours of instruction in teaching yoga and Ayurveda, which is, if you're not familiar, it's just a sister science to yoga. And it's thousands of year old medicine that's still practiced today. And so I combined all of that into one integrative approach, integrating science and mindfulness to elevate health and well-being. And that's why I put my registered trademark on the bottom, Elemental Wellness. So just a little more, I promise we'll talk about sleep and DMD and stuff, but just so you kind of understand where I'm coming from and what my style and approach are. That as of May 1st, I actually sold my dental practice. And I sold it to my part-time associate, and now I'm her employee. And so I stayed on part-time because I'm not completely done with dentistry, and also because I want to devote more time into alignment, breathing, and sleep. So alignment also being Invisalign and making sure the arches and the muscles are balanced and the joints are stacked, and also that people are breathing and sleeping. Because what's in it for you guys today, I hope that you come away with two things. One is a greater awareness of just how pervasive sleep disordered breathing is. And there are people in this room, statistically, a few of us, you see patients every single day who are affected by this. And it impacts the outcomes that you achieve. So my hope is that we'll also collaborate, that I can help you guys with your patients. Because if they're not sleeping, I hope to demonstrate through this, that they're not going to understand your directions. They're not going to remember them, even if you print out beautiful photos and directions. They're not going to be motivated because they may be struggling with depression or trauma. And they're going to have more inflammation and a heightened pain experience. So you're not going to be able to achieve your mutual goals with your patient as readily as if they're sleeping, having quality sleep. That's where we can collaborate. And likewise, I'm going to have some patients who have hypermobility or muscle imbalances or misalignment, and whether it's from therapies that I provide or just pre-existing conditions or things that happen, injuries. And I really I benefit from having, partners that I can refer to. And it's great that you're just up the street. I'm just down, you know where I am at all? I'm Bloomfield Ave. So right across from St. Gabriel School. So just a hop, skip, and a jump from this office. And I do have patients who come to see me from 45 minutes, an hour away. So for folks who are live streaming, this pertains to you too. So, all right, so let's begin. Also, the format, nobody likes a talking head, myself included. So if you have questions or comments, let let me know. Live stream people, I'm going to rely on Chris to let me know if you do have a question. And if I'm not seeing you, just like be more, exuberant or something. I don't know. Let me know. Okay. So we already talked about kind of what I hope to get across today. So I want to spend some time making sure we have the same knowledge and understanding. So what are sleep apnea and sleep-related breathing disorders? So the definition of apnea in adults is at least a 90% reduction in airflow for at least 10 seconds. So if someone stops breathing for 9 seconds and their oxygen starts to desat, it doesn't even count. It didn't even count as an event, right? In children, it's a lack of airflow for 2 breath cycles. And so I tell my patients, apnea is like choking. It's like, Annie, are you okay? Like there's really no air coming. Hypopnea, hypo meaning under or less than, right, is at least a 30% reduction in airflow compared to baseline, accompanied by either a 3% oxygen desat or an arousal. An arousal does not need to be something that the person remembers. Most often they're not. They're what we call microarousals. And so it's enough to fragment that sleep and kick them out of whatever stage they were in. We'll review the sleep cycle in a little bit. I did put in italics that Medicare thinks they know more than the American Association of Sleep Medicine Physicians. And so they say, no. It doesn't count unless it's a 4% oxygen desaturation. So what does that mean? They're just counting less events and they're underestimating the severity of disease. And it may make it harder for patients to get the care they need. And then we have respiratory effort-related arousals, or RERAs, and those are a less than 3% reduction in oxygen that is accompanied by an arousal. And we'll see why those matter. All right, the apnea-hypopnea index is, in my opinion, a broken ruler, but it is the measurement tool that we have. Completely arbitrary. It's the number of apneas plus the number of hypopneas over the total sleep time. And it gives you an average number of events per hour. We already talked about, like, if it wasn't 10 seconds, it didn't count. Are we using Medicare? Are we using a sleep medicine definition? So it may underestimate. And then it's completely arbitrary. If less than 5 times, you're considered normal. 5 to 15 mild, 15 to 30 moderate. Over that is severe. So if you think about that definition, I have patients who have AHIs greater than 60. So on average, they're stopping breathing at least 10 seconds of every minute of so-called sleep. And you wonder why your patients come in and they look like a train wreck, right? I had a bad sleep last night myself. And I'm like, how do people function when every night is like that? It's really very sad. So we want to help patients. Just some definition differences, the difference between AHI, RDI, ODI. Basically, we talked about AHI. RDI is a respiratory disturbance index. Sometimes we say REI. And that's the same thing, apnea, hypopnea, but now we're also including the more subtle desats and arousals with the RERAs, the respiratory effort-related arousals. And then oxygen desat is what it says, the number of desats over the total sleep time.
What are you using to determine all those? Is it sleep study only? Is there anything at home that they use? Like, would a watch be accurate to determine some of that stuff? Like,
you're stealing my thunder, Jason.
Okay, I'm sorry. You said ask questions. You didn't want to talk.
No, I totally love that. No, I am going to get to that. So the short answer to the question of how do we measure that? How is it measured? Is via some sort of sleep test. The wearables, the smartwatches and devices, and then we also have what's called nearables, where it's going to be remote to your phone with an app and all sorts of things. They're not quite there for diagnosing apnea and sleep-related breathing disorders. But as you know, technology is like, and so we're going to get there, especially AI reading sleep tests. We're not quite there yet. So the short answer, or long answer, I guess, is that I let patients know, hey, your watch is giving us information. The truth is the watch may under or overestimate the sleep time by 75 minutes. So what's that doing to our ratios? Like, But if they're wearing their CPAP or they're wearing a mandibular advancement device, right? We'll leave that out front and center, which is upside down. There we go.
We could tell.
Yes, I know you could tell because you're in the front row, Jason. So, but if they're seeing a difference in what their watch or their smart device is telling them, and it's a positive difference that goes with being compliant, that motivates them. And I'm like, yay, great. So I don't tell anybody, go out and buy an Oura Ring go out and buy an Apple, Watch. But if they have that already and they like it, then I try, just like you guys, meet people where they are. Try to meet people where they're at, respect where they're coming from, and see how we can educate them that that's information. It's not the end all be all kind of thing. So, all right. So on a spectrum, the continuum of sleep-related breathing disorders is you can have primary snoring, which isn't technically a breathing disorder, but if you're snoring, you're having trouble breathing. And chances are, if we don't do something about that, it's going to progress to upper airway resistance syndrome. That's the next slide, don't worry. Or hypopnea or apnea. And what we see oftentimes is there'll be undiagnosed snoring or upper airway resistance in, say, a young, otherwise healthy-looking female. And then she goes through the pause, and things change, and hormones shift, and now she's in full-blown apnea. But what happened to her in those 20 or 30 years when she was having trouble breathing, but we didn't know it, and she didn't know it? She just thought she was a working mom, and she was tired. She had some anxiety. She had a little thyroid issues. She had a little trouble with her weight. Is that like everybody that walks in, right?
It's 90%.
Yeah, it's Jason's patient pool for sure. You sat there. I mean, all right. So, So upper airway resistance is characterized by multiple arousals during sleep that prevent maintaining consistent sleep. And again, these are usually microarousals of which the person's not aware. They're going to be tired. They'll often have cold hands or feet, little Raynaud's phenomenon. They may have low blood pressure or orthostatic hypotension, so they're dizzy or lightheaded easily. Especially, this time of year, it's hot outside. They bend down to weed or play with their kids, or they're at the beach and then they stand up and it's like, whoa, we don't want the lights to go out. They may have trouble with insomnia, temporomandibular disorders, reflux, asthma, and allergies, because these all live together, and unrefreshing sleep and chronic fatigue. So they may also present with fibromyalgia and or depression or other mood disorders. So it is real. And I like this quote from the World Health Organization, that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, right? So just because somebody looks okay doesn't mean that they don't still need our help, right? Maybe we can prevent some of this stuff or mitigate some of this. So how do we diagnose obstructive sleep apnea? Is with a home sleep apnea test. That's the most common one. Insurances usually do cover it. If not, I think they run around $400, give or take. It's a device that a patient will bring home with them and wear for 1, 2, or 3 nights, depending. And it's unattended, so nobody's watching them. Nobody knows if they actually followed those directions and hooked it up right. And I have seen intelligent people struggle with the directions. So, people with dexterity issues or maybe that are having cognitive issues because they're not sleeping, it's hard to do this test right. The main point of the home sleep test is it can never rule out obstructive sleep apnea. That's my main thing. It's never going to come back normal. Even if somebody says, oh, it was normal, it's inconclusive. So if someone has a home sleep test and we have a reasonable suspicion that they might have sleep apnea, it warrants a polysomnogram or an in-lab. So the polysomnogram is the standard. That's where it's attended, full stage sleep staging, excuse me. You're going to have left and right electroculograms, electroencephalogram, cardiogram, limb EMGs, respiratory effort, chest and abdomen, oxygen saturation, and airflow. It is a true sleep test, and it can also diagnose other sleep disorders. So this was a very... That was great timing. This is a very old slide of my son, who's now 23, but he was open mouth breathing at night. He was open eye sleeping, maybe had a little behavior issues. And so they did not take his tonsils. They went for adenoids and some roto-rooter in his nose, but he still has trouble. I made him an appliance and I've got him mouth taping because this was from childhood. So I don't treat children, but I screen them. All right, and the wearables we kind of talked about, so I'll go over that, unless anybody had any other questions about wearables, the Fitbits, the Apple Watches. Okay.
Yeah, it was just more of a, could you use that as an indication of like, what would we look at for that to know that a person maybe would want to get tested or something? Is there anything on there that would be like, oh,
I don't necessarily, I don't necessarily look at that, but
Okay.
I am going to give you some other things to look at, like just 3 simple steps, how you can
Oh.
screen and how patients can self-screen. Yeah. So the sleep cycle, I do want to spend a minute here. For some people who may have studied sleep years ago, you may have learned 5 stages of sleep. The current model is 4 stages of sleep. So I don't want to insult anybody because when I studied this, I did not know this.
I'm insulted.
You're not there. Okay. It's all right. We'll give you love. We'll give you love. Your emotional wellness matters to me too. So, okay. Yes.
She knows you.
So the current model is 4 stages of sleep. REM that we're pretty familiar with, rapid eye movement, right? And then everything that's not that is non-REM. And it's abbreviated N1, N2, and N3. So I rendered this as a pie and as an analog clock because a full sleep cycle, if we start at the 12 o'clock position and go all the way around, takes 90 to 120 minutes to complete a healthy full sleep cycle. And REM onset latency is 80 to 90 minutes before you get to dream sleep. If someone's falling into dream sleep before that, they're either very sleep deprived or they have narcolepsy. So that's a thing, right? On the regular. I mean, we all have flukes and things like that. So N1 sleep is only about 5 to 10% of a sleep cycle. And hopefully we're going to have 4 or 5 sleep cycles a night. That would be wonderful. Then you're going to wake up feeling refreshed. But N1 is that light sleep where you're just falling asleep, where like your partner's in bed reading and you go brush your teeth and then you've come back and they've already shut the lights off and they're like, oh, you just woke me up. It's like, no, I didn't. You didn't have a chance to get sleep and cut it out. So, but that's that la sleep. It's where you're in a lecture, not like this presentation that's so engaging, but another lecture where you nod off and you just like, your head jerks, kind of that thing. You've ever woken yourself up. That's a hypnagogic jerk. That's normal. And is not restless sleep, restless leg. It's not periodic limb movement disorder. That's just a normal part of falling asleep. So that's okay. Then we get into N2, which is almost half of a sleep cycle. It is light sleep, and it's responsible for memory, learning, and everything else. So I like to say it's like the old disc defrag, or when you go home tonight and you're having beautiful sleep and thinking about this before you go to bed, like your brain will start putting all the information in the right files and buckets to remember and consolidate this information. So if your patient, makes it into N2, and then they have a night like I had last night where the one dog that's on the chair is like rustling around and then she's on the floor and it's like on the hardwoods and that wakes you up, you don't just go back to sleep where you left off. You go back to the beginning. So now you go back to sleep again, sleep, and your partner is either Darth Vader breathing or snoring or what are they doing? They will not tape their mouth tonight. Like, what's the problem? Again, you're woken up. You got to go back to the beginning. Now, sleep. You're somewhere in N2 land and it's hot. And when you go to roll over, your old dog at your feet of your bed is in the way. And you're like getting a little cranky now because you want to sleep because you got stuff to do. But no, you don't go back to sleep where you were. You go back to the beginning. So you can see how a lot of our patients are just cycling like Big Ben Parliament. Like they're just keep going back in and out of that light sleep. They may have trouble, again, remembering your directions, may have foggy, fuzzy brain, understanding them. Then finally, the miracle of miracle, we get through light sleep and we get to N3, which is the first stage of deep sleep. And during N3, that's also memory and learning, it's considered when the glymphatic system is active. So that is when the brain cells kind of shrink and cerebrospinal fluid just comes in like the street washers at night and flushes out the amyloid and the toxins and all the gunk and the crap. So if that's not happening, your patients are more susceptible to Parkinson's and to Alzheimer's and to other cognitive deficits. So they may have nodded like this when you told them and explained everything 5 times. Right. And then they go home and they didn't get it. They didn't keep it, right? Or they may not.
Will it affect their healing cycle at all as well? So recovering from injury?
Yes, because it's inflammatory. So all that junk and crap is inflammatory.
Mm-hmm.
All disease is inflammatory, which again, that's the last slides. Damn it, Jason. No, I love that you are thinking and that this is piquing your interest. And you're drinking caffeine. I don't know. But anyway. Okay.
Let me have caffeine.
All right. Yes, I see why. No, but exactly. It does affect their healing. And that's the other part that I'm hoping that you're seeing, not only their understanding, but also their inflammatory response and their pain experience, which, miracle of miracles, they made it through N3 and now they're into dreamland. Thank goodness, right? Because non-REM sleep, we call sleep to remember. REM sleep, we kind of call sleep to forget. But it's not sleep to forget. It's really sleep to attenuate. So let's say I was driving here today. Oh, I'm going to back up the car just one little second. In REM sleep, we're in complete paralysis. The only muscles that are active is rapid eye movement, the eye muscles, and the muscles of respiration. Why in the world, whether you believe in God or evolution or something in between, why would we be designed to be so vulnerable to predators an hour and a half to 2 hours every night where we couldn't protect ourselves? Right. There's got to be something important happening then, right? It can't be for no reason. So the current understanding about REM sleep is that when we're paralyzed, we're able to re-experience the stresses of the day without responding viscerally. So here comes a car, cuts me off getting on the freaking on-ramp. I slam on the brakes, tighten my glutes, my quads, grab the wheel, my lats, all my muscles, right? I tighten my jaw, my breath becomes rapid and shallow, my blood pressure goes up, my heart rate goes up, my cortisol surges, and it doesn't just come back down, right? So and how many people are living like that all day long for one reason or another, right? It's believed during REM sleep, that's the opportunity to attenuate that stuff. Because just like if you meditate or if you're into yoga or if you just think about watching a movie, you can watch the car cut you off, but now you're not slamming on the brakes. Now you're not gripping the wheel. Now you're not having those surges, right? So it can kind of attenuate the experience. So our patients that are not going through that, maybe they've had an injury that puts them in your clinic that was traumatic. And now they're having PTSD and they don't even know it. Maybe the injury or that they're working on has affected their activities of daily living and their quality of life, and they're depressed. They may or may not know it. Is that going to affect the outcomes that you have? 100%, right? Maybe they're just living in a constant state of anxiety. And that, my friend, is insomnia's bed partner, because you don't live in anxiety all day and cortisol overload and then shut off the lights and think you're having good sleep. It doesn't happen, right? So I talk to my patients, sleep patients, all patients, that sleep hygiene isn't just what happens like the hour before you go to bed. It's what you do all day long. What and when do you eat? What and when do you drink? How, when and how do you move? How do you manage stress? All of that. So, any questions on anything so far? Yeah.
Even digestion?
Yeah.
Process? No, like digestion during the...
To my understanding, that's a great question. So Ayurvedically, eating before bed is not good. And even scientific, Western science or modern science, I advise patients not to eat a few hours before bed if they can help it, unless they have a reason they need to have a little snack with a medication, or if they're just starving and they need to have some nuts or something. But yeah, a heavy meal is going to disrupt your sleep because that's when your body is intended to detoxify, not to digest. And so it's going to ramp up your sugar, your blood sugar, and just put your body, instead of your vital organs of detoxification, instead of your liver and kidneys and everybody doing what they're supposed to do, they're like, oh, here's another meal to digest and process. So you're going to, a lot of times, either wake up with a brick belly or loose poops, right? Because it didn't digest properly and the person didn't enjoy the nutrition from that meal, kind of thing. Okay. All right. So really quick, there's a lot of words on this, but not so fun facts about sleep is 70 million Americans suffer from some breathing diagnosable sleep disorder. So that is 1 out of every 5 of us. Oh, I didn't see. Yeah, Alex.
Being directed a certain way. So sleep at night. Just like if we're giving patients complex disorder, I'd be able to add like, maybe it's more testing and
Love it. So if I'm going to paraphrase the question, correct me if I got it right, is basically, is there a benefit of doing certain kinds of exercises or certain kind of movement or activity at certain times of day as far as the efficacy of the movement and also the impact on sleep?
or just being mentally productive, like as soon as you start to get up versus like waiting and scrolling on your phone for 2 hours and then starting.
I love you, Alex. Yes. That is elemental wellness. Yeah, that we definitely do. Our bodies are programmed that way. And so most of us, when we're in tune with our circadian rhythm, which is another whole talk that I'd be happy to talk about, is we are more productive in the morning. So the wee hours of the morning is more of that meditative, reflective time. It's a good time to journal, pray, meditate, whatever it is that your particular reflection is. I didn't hear it. Okay.
Do notes.
Do notes. Oh, that's not the best time, I don't think. Well,
Ideal.
yeah, the best. Well, it might be productive, but it's probably not good for your, And then yes, the heavy lifting, whether it is physical weights or creative work or really like getting in the grind, the morning is most of our best time for sure. So if you have patients perhaps that you're asking them to do physically harder or more physically demanding things, the morning is a better time. If you're going to lift weights, the morning generally is a better time than the evening. I think sometimes when we're in our 20s and stuff, we can kind of get away with that. And then as time marches on, you're like, yeah, that's not my best time to work out, really, And then maybe have them do like the more gentle stretches closer to bedtime. That'll help to wind down and help have better sleep. Like I think it's generally, we understand that you shouldn't do something that increases your temperature, your heart rate, your blood pressure before too close to bedtime, because those are opposite of everything that promotes sleep, right? We want to do things that decrease blood pressure, decrease temperature, decrease heart rate, decrease respiration. Those are like wind down things the hour before bed. So, yeah, I think it's cool. Yeah. Did that answer the question? Okay, cool. You're welcome. Most welcome. So here's the other one. 80 to 90% of sleep disorders go undiagnosed. So that's a lot. And you can have more than one sleep disorder. It's so common to have apnea and insomnia together that they made a cute little acronym, COMISA, comorbid insomnia and apnea. And so it's an education to patients. Like, hey, if I can help you to sleep through those apneas, if I can help you address the apneas, so you're having fewer of those arousals, maybe you'll have less trouble with the insomnia. And we got to look at both, right, in order to give you the best outcome. So insomnia is not what I had last night. That's not chronic. It's just what I had last night. But the definition is having trouble either initiating sleep or resuming sleep, 30 minutes or more, 3 nights a week for 3 months or more. I know you have patients who are struggling with that. And the number one treatment for that is cognitive behavioral therapy for insomnia. It is not a pill. The benzos, if they have COMISA, it's going to make the apnea worse because they're sedative and relax the muscles. So all of that. But I want to make sure we get through everything. So how are you going to recognize if it's not the smartphone? Or the Oura Ring, which does have information, but I don't particularly look at that. I look at the medical history, and you guys are looking at that with every patient. So what are some signs or symptoms of OSA? Cardiovascular, high blood pressure, right? The body's not getting enough oxygen. Let's push out more oxygenated blood. AFib always starts with hypertension. And it depends on what study you look at, but up to 80% of patients with AFib have apnea. If you have someone who's medication-resistant hypertensive, they're on 2 or 3 more meds, I can bet you a lot of money they've got apnea. A lot. And it's about educating our peers. So that's also part of what I'm doing in my transition of my practice is I want to meet with cardiologists and other groups to be like, hey, let me help you. Let me help our patients because we can do better. You know, congestive heart failure, awful, awful, awful. Heart attack and stroke. I mean, you guys see these people on cardiac rehab, on all sorts of things coming into you. Yes, you have these folks. Yeah. So that one. And congestive heart failure, we won't spend time on that. Diabetes is another one. Because of the sleep cycle disruption, you've got hormonal dysregulation and cortisol dysregulation. So that's going to screw up the blood sugar levels. Thyroid disease is underappreciated. It has some, I'm not in the position today to explain it completely, but with weak upper airway muscles and mucositis, then they have lethargy and weight gain, and it just all becomes like a big snowball. Okay. But thyroid disease is often seen in sleep disorders as well. Obesity. So obesity can be both a cause and effect of apnea. With obesity, ghrelin, the hormone of hunger, that's produced in the GI tract, that's upregulated. So the person's getting messages, I'm hungry, I'm hungry, I'm hungry. And the leptin, the one that's made in the fat cells that says I'm full, I'm satisfied, that's downregulated. So they're like never satisfied. And now they're gaining weight. And well, if you just lose weight, well, if it was just that easy for them, they would, and they're tired too, and they're depressed. So it's hard to exercise when that's the case.
Right.
Acid reflux, big one that's under-recognized too. So, I'm just on famotidine, omeprazole, pantoprazole, like every day you see in these people. Or they don't think it's important to mention. But
Right.
I don't know if you guys experience it when you have them lay down on the beds, but in the dental chair, I can't lean back. I can't lean back. I post nasal drip. I'm like, oh my God, you don't have post nasal drip. You are sucking on your own uvula. You're choking on your own anatomy. And I don't say it like that because I am very caring and compassionate, but we know that I'm like, oh, okay, I'm going to look in that throat, in that airway, because it's probably not postnasal drip, or it's probably anatomy plus postnasal drip. So when they're mouth breathing, the air is not warm, filtered, and conditioned. It's all the dust particles, allergens, pollutants are glomming right on that delicate tissue. I tell especially my ladies, that tissue in your throat, it's the same as in your vagina. Right. You want to have a hairdryer blowing up your vagina all night and see how you do in the morning? Maybe Jason shouldn't say that, but
once.
But
I'd say it once.
No more. Yeah. So, but yeah, you wouldn't be healthy. There'd be issues, right? And so these tissues get very inflamed when they're dried out. They just want to get moistened up, so they get swollen, they get mucousy, and that's what the patient is feeling. They're feeling these tissues are enlarged and they're slippery and they're slimy. It feels like postnasal drip for sure. But what happens is, person stops breathing, carbon dioxide starts building up. We know that it's not the oxygen that drives respiration, it's that carbon dioxide that drives respiration. So now the body's like, whoa, I better breathe. But they're lying down in bed. So they breathe, and their belly is like a bellows, and it propels stomach acid up into the throat, irritating the throat. We've got patients with Barrett's esophagitis. That's pre-cancer, people. And that's coming from your belly. Why? Why are you on that medicine you're only supposed to be on for several months, and you've been on it 20 years? Has anybody ever wondered? Is there an anatomic reason? Is there a diet reason? Is there a lifestyle reason? Are we eating too heavy and full before bed, right? Or are we just not processing our stresses? Why? It's not normal. Or do you have apnea, and every night your body tries to breathe, and inadvertently it pushes up some acid. And it also corrodes the teeth and gums. So I'll show you a picture of that. Moving along. Mood disturbances we talked about. You're not getting into REM. You're going to have depression, anxiety, PTSD. The other parts of sleep, ADD, ADHD. Big time. Patients having, no calling, no pointing. Brain fog and memory issues. Relationships, snoring. Bed partners lose more than an hour of sleep when their partner is snoring. Yes, Alex?
Has there been any studies on the relation between ADD and ADHD in kids mouth breathing? Right, others?
I don't have a specific one. I can look to see. So the question was, is there a study that demonstrates a relationship between the rise in ADD, ADHD diagnoses and sleep disorders. There's absolutely a connection, and more than a correlation. There's causality for sure. That 7-year-old that's still wearing pull-ups and sleeping with their mouth open and has bags under their eyes and the long face, and they're like, ugh.
Right.
They're not just an annoying little kid. They can't breathe. So I can look afterwards for some studies for you if it shows that why that is. I mean, we also know there's more obesity, there's more inflammation, there's less activity. These kids aren't playing. They don't have core strength. And we've disevolved. Has anybody read Breath by James Nestor? Ryan has. Yeah. So we've disevolved because we cook our food and we've processed our food. So we don't have to chew as much. So we traded those prognathic mandibles that could chew anything for being able to speak and sing, but we can't breathe. We're all crowded. If you look at more traditional populations that are less developed commercially, they have beautiful teeth. They don't have decay. They've got these beautiful arch forms, gorgeous teeth. And then they start eating junky food, and over the generations, now they're crowded. Now they've got decay. Now they've got gum disease. So on that note, erectile dysfunction, right? That naturally segues from there.
Decay and erectile dysfunction.
Yes. But yeah, if we're not sleeping, it's real for men and women to have sexual dysfunction, because you need to get into that rest and digest mode that nourish your parasympathetic so that you can become aroused. And then orgasm is sympathetic. But if we've got poor blood flow to the important parts and we're just living in cortisol overload all the time, it's going to impact things.
Right.
So what's the face of OSA? This is my great dog nephew, Oscar, and he doesn't have sleep apnea. He has awake apnea. Like, have you ever seen these poor little guys? Like, they can't breathe, they can't digest, they can't have babies. Well, he's a boy, but he wasn't born vaginally, right? So these guys have a lot of health problems. But what do I see and what might you see? So first thing we're going to review is, are you snoring? That's an easy question. Second one is going to be what I'm showing you here. And the third one is, what's your medical history? Because everything we just went over, and I will sum that back up again. Those are only 3 things you need to know to screen for apnea. And then you send them for a referral. Okay. So kids, again, I don't treat children. I do screen children. Those 5 to 7-year-olds, 3 to 7-year-olds that are having the behavior issues, the ADD, the ADHD, the bedwetting, and et cetera, et cetera. The tricky thing is, half of them will grow out of it-ish, and about half won't. So that's a conundrum. That's a tough decision for a parent and a child and the pediatrician. Like how when it's such an important time for your child to be learning and socializing and affecting the rest of their life, those 0 to 7 years, right? But they're not fully living and breathing and sleeping. It's a tough decision. So I don't cast judgments on that. It's just a tough one. So some of them, we take out the tonsils and adenoids. Sometimes we watch.
Right.
But this is what you can see. You could see this when you talk to somebody, right? You don't have to be a dentist. There's people who have very small mandibles, or they're retrognathic, so the lower jaw is shorter than the upper jaw. And then this is an old scan, so it doesn't show the whole palate, but this is an upper arch when you're sitting on the tongue looking up. And you can see how it's kind of Gothic arch. It's more beak-shaped in the front. That's someone who has a narrow, vaulted palate. And what was it, the chicken or the egg, right? Did they form that way and they couldn't breathe after that? Or do they have a tongue thrust because they couldn't breathe? Like, it just all goes together. It just all goes together. They've learned to make a straw out of their tongue to breathe. And so this is what we've got. Splayed teeth. So with my virtual pointer, that bottom one, you can kind of see spaces between. The person has a nicer arch form. It's more of that Roman arch, more of that rainbow that we're looking for, but they have spaces between their teeth. And maybe those have gotten more over time because of a tongue thrust. They are trying to get their own tongue out of their throat so they could breathe. Ankyloglosia. So on the left is a patient of mine who I asked her to put her tongue to the roof of their mouth, and that's where she could go. Like that frenum, that lingual frenum muscle is just really short and tight and attached. So I released her with laser. She didn't have to have an injection. It's pretty easy for her. And it's not a long procedure. And immediately, I don't know if you can see with the glare, but you can see her uvula and you can see some airway. And she reported that very first night that she could sleep better and breathe better, which was amazing. With that, it's great if we also work with oral myofunctional therapists to do more oral physical therapy, essentially. I don't know how much you guys do or don't do that, but that does help to do that beforehand and after. Because you see patients all the time when they've been immobilized. Like I'm speaking from experience. So I had a traumatic injury and fractured the head of my humerus in 4 places in my dominant arm as a solo practicing dentist. So it was not a good day. And so my plate and my 9 bolts and a lot of rehab, and we're good. But when I came out after 7 weeks of a sling, I was Dr. Shaky Hands. I was like, oh my God, the atrophy, right? So these tongues don't know how to be anyplace else. They've been in a sling the person's whole, however many decades of life. So they need help. They need to learn how to be in healthy places, how to swallow again, how to breathe again. All right, so the terrible slide, it just shows scalloping on the sides of the tongue. You can't see anything else on the person's face, and she wears a CPAP, thank God. So sleep bruxism is a sign. Oftentimes, I used to make a ton of night guards for grinding and clenching, and then I learned more. We know what we know, we don't know what we don't know. Now I'm like, is that just clenching and grinding, or is something else going on? Are their teeth flat because they're trying to open their airway? Right? Are their teeth flat because they've got acid reflux and they're trying to open their airway? This is a patient, and it was so sad. She was a patient for decades. I don't know if you can see on the scan that the gum line, it's all notched out and kind of yellowy and gold and amber because it's into the root structure. For some people, this is very sensitive. Other people, doesn't bother them at all. It's completely individual. But this is the effects of acid. And 9 times out of 10, I can tell how somebody sleeps. I see she tosses and turns, but she prefers to sleep on her left, a little bit on her face, because she's got more wear there. That's silent reflux. They may not even know they have that. Do you have reflux? No, I don't. Well, what is doing this? This is acid. It's shiny. That's not an eating disorder. Eating disorder, I'll see that on the inside, upper teeth inside. Alcoholics reflux, I'll see that on the upper inside. This is on the outside. So like when you're sleeping here and the acid comes up and now it pools and they're just sitting in acid all night.
Right across.
Small airway. Are you able to see this at all or no? Ish? Okay. So this is an example of someone who is wearing a CPAP, but look at that party trick. You can see her big old uvula. And then how does she do that with her tongue? Because she doesn't think about it. That's what her body learned to do so she could breathe. So people will do interesting things when you just look in their mouth. So you don't have to be a dentist, but you couldn't see. When they stick out their tongue, they're awake and upright. If you see just pink stuff back there, what do you think is happening when they're horizontal and they're REM paralyzed? It's probably not so good, right? They're probably not breathing well.
Right.
This is a patent airway, but this person has upper airway resistance. She already lost her tonsils. Her uvula is not so bad in this picture, but she's doing a little party trick too. She's trying to breathe. So just because someone is underweight or looks normal or you can see the airway, it doesn't necessarily mean they're okay too. A collapsible airway is a collapsible airway. So just like we have metal straws, plastic straws, and paper straws, I let patients know some people just have a very rigid metal straw of an airway. Some have those plastic ones that are in the middle, and then some of us just got those paper ones and they'll collapse easily. That's just what you got, Are there ways we can help with that? A little bit, oral myofunctional therapy, but some part of it is what you got. Large neck circumference, you see this coming through. I've treated 18-year-old football players who were snoring and their roommate was like, oh, that's funny. It's not funny. Look at this guy's neck is wider than his head, right? A lot of professional athletes, they die suddenly of heart issues. How did they have a heart issue? Maybe they weren't breathing.
Right.
What's heavier if you got a pound of chicken breast, not a pound, excuse me, a cup of chicken breast or a cup of lard?
Right
Muscles. The muscles are more expensive. More expensive. They are more expensive. The muscles. Oh my gracious. The muscles are heavier, volume for volume. So when he lies down and goes into paralysis, he chokes himself out. And that's a terrible picture. It's not a picture of kyphosis. I couldn't find a good one, but it is forward head posture. And you guys see that all the time, trying to rebalance that. So these are things that you see. We talked about weight. I'm not going to deal with that. So how can you screen? It's not necessarily the watch or the aura. Like if they bring it up to you, that's great, but I don't rely on that. Do you snore? That's a red flag waving. Doesn't mean you have apnea, but it concerns me. Stick out your tongue. Do I see an airway or do I just see pink? That's another red flag waving. And then what's your medical history? Do you have high blood pressure, congestive heart failure, AFib, heart attack, stroke, diabetes, thyroid, depression, anxiety, ADD, ADHD, diabetes, reflux? And are you on 2 or more medications for that? Because maybe we better talk. Maybe that warrants a sleep referral. And I do have a TEDx style talk. I don't know if you can grab that off with a very long link, but that talks about that. So when we're in how to refer, for dentists like myself, you can go to American Academy of Dental Sleep Medicine and find a dentist who is qualified, like we talk about. So diplomate ideally. When to refer? As soon as possible. I am not a cowboy. So I used to send patients home with home sleep apnea tests and have it read remotely. But then it came to a problem like, I really want to share the responsibility. And what happens when I get that one that comes back inconclusive? Now I've got to refer them for a polysomnogram, and that's a bit awkward. Why didn't you just send them to me first, doctor? Right? So I was like, I think it's better patient management that I work with the sleep providers. So I work with multiple offices all around the state, sleep providers, to get the diagnosis. Then they come to me if they don't want to wear a CPAP or they don't want to have a surgery, and I can help them with a mandibular advancement device. So these leads me to a beautiful segue. Yes, on the top left, CPAP is an option. That's been the gold standard. The very first CPAP, you know where the engine came from? Somebody's going to get a free book. Come on, say it. Vacuum cleaner. They put it in reverse, and it was that loud. But it's just a garden hose of air blowing down your gob. And so it's really effective because it can blow the airway open. Everything has a potential side effect. Some patients develop dermatitis, eye infections, sinus infections, air in the belly that's really uncomfortable, or claustrophobia, or everything else. So not everybody can do that. I never talk someone out of a CPAP who's successful with it, who's enjoying it, who's being controlled, their sleep problem is being controlled. I never talk them out of that. I just reinforce it every time they come in. How's the CPAP going? You still wearing it every night? You stop. All right, let's get you back to the pulmonologist. Let's try a different mask. Let's, something else. So we're always doing that. This mask is not a full face. So people who breathe through their mouth, who cannot breathe through their nose, they have one around their chin as well. Nasal pillows are really popular right now that are just in the nose. Bottom left, who knows what's missing? Uvula, yeah. So we don't do that procedure. I never did it, but surgeons don't do that procedure as much anymore. They use UPP, uvulopalatopharyngoplasty, because it didn't work very well. And it's really barbaric. And now where did their gag reflex go? Right. So those are less in style. You may be familiar with Inspire. That's a surgery in your ribs to implant the sensor to see if you're breathing, and then a surgery to dissect your hypoglossal nerve and make you a human Pez dispenser anytime you stop breathing. I have learned from my sleep colleagues, I did not know this, that some patients complain that they're raking up their tongue because they're going on that. So that doesn't mean they can't do it. It's like, oh, come see me. I can make you something really sleek and to protect you from your teeth at night. Because probably before they got that, they were clenching and grinding and chipped the heck out of their front teeth, and they're jaggy anyways, right? So now they're raking across it all night. And then a mandibular advancement device, like so. It just brings the lower jaw forward a certain amount during the night. There are many different styles and designs. This is one that I use frequently, not because it's sexy, but because it's very durable and predictable. And should somebody have some fillings or crowns done or something, I can generally adjust this internally so they don't have to get a whole new appliance. They're harder to break, but there are other designs that can be used. And I let patients know, studies show for how far forward they possibly could bring their jaw, half to 75% of that distance is usually the sweet spot. So I'll usually start them around 50%. These are adjustable. I did not bring an adjustment tool today, but they're adjustable, and I'll see the patient back however many times till we find where their subjective symptoms are better. And then I will refer them back to the original referring source to have a verification test to see how subjectively they're doing. What I meant to mention before about that apnea-hypopnea index is I think in the next 5 years, we'll get away from that as much and go more to hypoxic burden, because that seems to be a better measurement of what's going on, but that's the ruler we have right now. But if people say subjectively, like, oh my gosh, I'm not falling asleep at meetings, I don't need a nap in the afternoon anymore, I feel refreshed, that's great. The hardest ones to treat are the ones who don't feel tired. They don't think they have a problem, so they're harder. All right, these are the last couple slides, and then anything we want to do. I know I took a little longer than I thought we would, and it's been great. So TMD and mandibular advancement devices. What's the correlation? It showed that people who have some symptoms beforehand may be more likely, or they have some joint sounds, they might be more likely to develop some tenderness with the appliance. But it doesn't mean that they can't try the appliance. And for some people, they've got muscular issues because they've been trying to advance themselves. Get them in a good appliance and they're like, wow, I feel better. So it's just something for me to know ahead of time. How you can maybe help me is if I've got patients with hypermobility or with pre-existing conditions or who develop an onset of symptoms when we do some oral appliance therapy, if you can help them to rebalance muscles and get comfortable. I do self-massage with patients. Every patient gets exercises by the American Academy of Dental Sleep Medicine that they can do while driving a car or watching TV to help keep things comfortable and minimize the chances of changes in the bite. So we really don't have a lot of that, but when you treat enough people, there will be some people who have those issues. So that's where I love to have you guys as a resource. Inflammation, what we were talking about originally. Yeah. So poor sleep is going to impact your outcomes, your therapeutic outcomes, because of the inflammation. The cytokines, interleukin-6 and C-reactive protein, it's the same stuff that's happening in periodontitis, diabetes, Alzheimer's, and cardiovascular disease. That's why if they have any of those things going on, that's part of this screening process. Like, okay, what's your A1C? You're on 3 things for your blood pressure, really? And your doctor still hasn't recommended a sleep test? If somebody's like 90, like my dad, yeah, we knew he had sleep apnea, but it was a little too late by the time we realized what was going on. I'm not going to bother them at that point. But in their 70s, even I've had people in their 80s who are like, I know I am at early onset dementia and I want to do everything I can to be as well as I can be. I'll treat them. Adults with intellectual disabilities, with support, I've helped them, so definitely. We talked about N3 sleep and just basically another study that shows, if they're not sleeping, there's more inflammation. You guys are going to have a harder time. Patients are going to have a worse pain experience. So together we do better, right? These are some good reads. Sleep Interrupted talks about not just apnea, but insomnia, anything else is disrupting your sleep. Say Goodnight to Insomnia is a 6-week self-help to reframe your ideas about insomnia. And basically it's just like zenning people out. It's like, all right, you're not sleeping, but that's not going to kill you tonight. Like you may be tired tomorrow, but you will be able to function. So let's just try to breathe from the belly. A lot of times people start getting anxious. They're like, I hate to go to bed. That's awful. We should love our bed, right? In the ideal world, but not everybody does. And then breath I mentioned too. Do you snore, stick out your tongue, and what's your medical history? That's all you need to know. Awareness, and then collaborate. And these are some cases that I won't go over now because of time. This is how to get me. I am in the process. So the best place is actually LinkedIn. If you want to message me directly, I will definitely get that. I'm just relaunching a new website. That's the top one, Elemental-Wellness. And that's a QR to my book, which I can donate one to you guys to share. But this is my book on wellness. It's got some movements back here you'll recognize. So look at this, all these movements, little yoga stuff in there, breathing, mindfulness, walking meditation, stuff that people can do. And going back, Alex, like when can they do those things? Like, yeah, walking your dog. Like, there's all sorts of little things in there. So that's pretty much what I got. And that definitely took 10 minutes longer than I thought, but we had good discussion, I thought. Questions, comments, thoughts? Anything?
Talk about the mouth tape a little bit. You kind of mentioned it casually.
Yes, I did mention it casually. So I used to think like that was weird, mouth taping. Mouth taping was the question. And now we really appreciate the importance of nasal breathing. And the book Breath talks about that too. Any breathing books are going to talk about that, the butyric method and everything. So when patients wear a CPAP or they wear this, but their mouth's open, they're not getting the ideal result. It's the mandible can still fall back. They're still dehydrating. They're still can snore through that. So I do have some patients wear elastics that help to promote keeping their mouth closed, and some I'll actually recommend them to use tape to keep the mouth closed and do that. And if they can't sleep like that, there's either a physical or a behavioral reason, or an emotional, psychological one. Yeah, but sometimes.
First night you think you're going to die.
All right. Are you saying you're talking for a friend? Okay,
Yeah,
but yes, yeah, and there is that too, and that's part of it, right? That's helping people. That's being in healthcare in service of people, is knowing that there are traumas or emotional issues around many things. So, yes.
I have a question about
Caitlin?
education. Yes,
Okay,
Caitlin. Patient education. Sometimes when I've tried to do like the sleep hygiene education, I have patients that, have worked multiple jobs their whole life. They're like, oh, I've only ever slept 4 hours, that's all I need, blah, blah, blah. So like in my mind, I'm like, okay, that's been a problem for their whole life. But I feel like for those patients, sometimes it's hard to get them on board with the sleep hygiene. I don't know if you have any suggestions for ways to like effectively communicate with them that that's a problem that needs to be addressed.
Yeah. So Caitlin was talking about patients who don't sleep enough, and they've done that for many years, and they don't think they need sleep. In Ayurveda, we call those the vatas. They're the people that are like, they're the insomniacs. They think that they need 6, 5, 4 hours of sleep. They're fine. They'll sleep when they're dead. And I'm like, yeah, you will die sooner because you need more sleep than that. And I know that you've functioned or you've dysfunctioned, but it really, there's so much science and studies that show that's not healthy for you. So maybe trying to find out what's still getting in the way of them having a healthier sleep and working incrementally. It's like, okay, 4 hours, can we try to get it to 5? Or if they really have to work 2 and 3 jobs and that's their life in this moment, when can we do a nap? Can you do a 20, 30-minute nap on a lunch break to try to make up for it? Ideal nap times are about 30 minutes. So I do give patients that hack, like, drink a cup of coffee, set your timer for 30 minutes, your phone for 30 minutes, and then try to get some winks in. If you fall asleep, great. If you don't, at least you're rested. And hopefully the coffee kicks in when you got to go again. But it is going to have ramifications. And you're right. The people who don't think they have a problem are challenging for us to help.
What is the recommended window? Like how much?
Sleep?
Yeah.
7 to 8 hours is ideal sleep. Yep. Some people need more because that's another Ayurvedic elemental wellness thing. Like our constitutions are different. Like, your body type and my body type are different, and, everybody else's. So some of us need more sleep. Some don't need quite as much, but basically most people need that 7 to 8. Yeah.
About like staying asleep. Like you want to get the 7 hours, but you can't.
Because
General, like,
the question is about staying asleep, having trouble maintaining sleep. So that goes back to a lot of sleep hygiene too. The other thing I didn't share about last night was I had caffeine in the afternoon. It was delicious cold brew, but it didn't like me at 2 and 3 in the morning. All right, I'm just saying it didn't work for me. Maybe for you it's okay. Maybe your cutoff is later in the day, but for me that wasn't. Yeah. So it is really the sleep hygiene for being able to maintain sleep is what happens all day long. So making sure that the exercise, the raising the heart rate and stuff is happening earlier, or at least not too close to bedtime. If you're working till 8 and you're trying to work out after that and then go to sleep by 10, that's rough. It's maybe not the best time. Maybe try to get up earlier instead of doing notes in the morning. Get up and exercise in the morning instead. Then you'll be more tired at the end of the day. Trying not to drink alcohol a few hours before bed. Some people think it's a nightcap that puts them to sleep, but then you get the sugar spike and the second pass effect, and it's actually waking you up. So try to do it more at happy hour if you're going to enjoy some beverages, and not right before bed. Managing your stress, meditation, mindfulness, and it doesn't have to be sitting in a pretzel pose. It could just be going for a mindful walk. So one of my, favorite mindfulness meditations is just going through my senses when I'm going for a walk. What do I hear? What do I feel? What do I see? What do I smell? And I missed one. What do I taste? Even if it was your lunch or you're thirsty or your toothpaste or whatever. And that just going through that process slowly for yourself in a minute or two can help to ground you. You can do it before bed. Also go through the colors. Just like when I'm walking the dogs, I try to go through the colors of the rainbow and see it. You just start to see things that you wouldn't see. It makes for more mindfulness, which can help. And cognitive behavioral therapy, so that Say Goodnight to Insomnia might be a resource. It's a very boring book. If that doesn't put you to sleep again, I don't know what will. But it does have, techniques in there how to reframe your thoughts about being awake. And then, yes, Janet.
Sorry. This is for Elena. She had to leave, but she was one of the people online.
Okay.
Her question was...
Hopefully she'll get the answer after.
Yes, I told her you would. For patients that don't test positive for sleep apnea, but would benefit from... would benefit from a mandibular device for TMD/snoring, what do you do?
So for patients who didn't have a positive test for apnea, but they still have signs of parafunction, grinding, snoring, I would still treat them with a device. I would.
She said, I know ads, is that how you say it?
Yeah.
These can be very expensive and in my experience are not covered by insurance if the patient doesn't have diagnosed.
Right. So and that's where that Medicare comes in too. Like if they're underestimating the severity or underdiagnosing. So yeah, an acronym is a mandibular advancement device. I don't like MAD, so I used to call it MAS, but everybody in the world calls it MAD. So these are MADs. If the insurance doesn't cover it, that can be a challenge for patients. Many insurances, if they already have a CPAP for a certain length of time, whether they're using it or not, the insurance is not going to cover both. What I have done in full disclosure is I've worked with, so I'm not a hospital. I'm not a 38 office organization. I'm me. I did work with like a clearinghouse, and unfortunately we had different values or philosophies, we shall say. Okay, so that was not a good choice over time. And then my team learned how to do the process. And in a small office, I would have team members on the phone over 2 hours, get a reference number, get a name, get a quote, get qualified for an out-of-network, what do they call that? When you're one-time in-network. I forget, it's escaping me right now, but get qualified to be in network with their insurance that one particular time. And then they don't pay until the patient has it. So now I already am like hundreds and hundreds of dollars into this and hours into my time. And then months later, we're like, oh yeah, your insurance didn't pay what they said. Who do they think screwed up? Me. My office doesn't know what they're doing. So unfortunately, or fortunately, I don't process insurance anymore. I'm happy to give patients the documentation they need, the codes, and help them. And we have had patients get success with reimbursement, but I greatly reduced my fees. So going rate could be $4 or $6. I heard somebody got $7,000 east of the river. That was not me. So my rate is $2,600. And they can use an HSA or an FSA. And that includes lab fees. It includes a 30-minute consultation. So I will talk to anybody for 30 minutes for free. So there's no obligation and no pressure. Some people come in and they go out. It's okay, right? That's what my model is right now. But if they choose to go forward, it's the records, it's any adjustments they need for the whole first year. And then I will see them at the 6-month mark. Hopefully they've had a verification test by then. I'll adjust again. I'll see them annually and make sure everything is working. Have they had any dental work? Support them with I mean, I do icy spray for people and a massage. Like I do a lot to support. We want our patients to be happy. I don't just give them this and say, give me your wallet and I'll see you later. After the first year, it's a very nominal fee. I see them annually. We get a little salty because you can't go anywhere. I mean, I went to the dermatologist for 10 minutes and it's $400. What was the overhead? I have a high deductible. Stuff costs money. This shoulder was very expensive with a $7,500 deductible. I met it January 15th, so I got all the talk therapy I needed that year and PT. I'm like, everything was good. But yeah, so that is what my model is. I hope that helps Elena. Yeah, there's some people who choose to, they're looking for somebody in network. Physician can't do it. They don't know how. It's durable medical equipment. It is not their dental insurance. It's medical insurance. And it's just banging our heads on the wall. I want to help people. So I reduce my fees and I got to be efficient, but we care. We take care of our patients.
So in a case like that she's speaking of, would you say that individual should be like go get checked out and evaluated, or would you say try mouth tape and see? Would you say what would you?
If they're already grinding their teeth and stuff, I would recommend a device to protect them from themselves. Yeah. And I do have some patients who just didn't get a diagnosis. It was primary snoring. I don't know, was it? Yeah, maybe they didn't have the polysomnogram. Maybe they didn't want to. You can't make people do it, but I'll still help them the same way. And there's lots of different labs. Like I won't use crummy stuff. Yeah. Did you have a question?
Is there any hereditary components to it?
Yes, hereditary components. So you can inherit your anatomy, and just like joint laxity, is your airway collapsible? So not just big necks are collapsible, but thin women have narrow airways. They're more collapsible, right? I've had people with BMIs of 18 have pretty significant apnea because it's just collapsible. So we all have to learn how to play the didgeridoo. That is the one yogic thing I have not learned how to do, but but that would strengthen our airway. But yeah, so, and you can also inherit your structure, right? If it's not end all be all, but a narrow arch form, a lot of crowding, that high vaulted palate. Yeah. So we do ask family history. Do you have any primary relatives, parents, siblings, or children who have any of those things we talked about? Oh yeah, my kid has ADD. How's their sleep? Maybe we got to help them too. They're not even my patient, but we have these conversations. Oh yeah, my mother, snored like a train wreck, and then she had a stroke. Okay. So we'll talk. Oh, my brother wears the CPAP. Yeah. So we talk about those things. Yeah.
Thank you.
You're welcome. All right. You guys have been a delight. Thank you. Thank you very much. I have some, thank you. So I have some referral pads if anybody needs more. I have some magnets if you want to give any to patients or put any on your fridge or anything like that. Again, I see anybody for a consultation without a charge. So I want to take barriers away. I want them to have a good experience and know that they can trust us and that there's options. And if we're not the right fit for them or they're trying to go in network or whatever, okay, we're here. I just call, I write back to whoever sent them to me and say, hey, so-and-so seems like they're going to try a different avenue. So we don't just throw it in the trash. Yeah. All right. Thanks, guys.
Thank you. Appreciate it.
Thanks.